بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the lecture number 10 in the series of abdominal imaging, and in this lecture we will deal with imaging of the pancreas. And you know that the pancreatic imaging can be performed by many other modalities like ultrasound, CT, and MRI. And we'll concentrate here on the role of the CT scan in assessment of the pancreas, because you all know that usually the pancreas is masked by gases during ultrasound examination, and the results are usually not sufficient, and the MRI has a limited role in the evaluation of the pancreatic pathology. I will explain this during my talk. Then the indications for examination of the pancreas by CT is to assess an equivocal previous imaging finding, such as the results of ultrasound, for example. Then one of the main tasks is the diagnosis and the staging of pancreatic neoplasms and the assessment of suspected post-traumatic injuries. Then the patient preparation is the usual preparation for abdominal imaging, and we have a scanogram and indicate the area to be examined from the level of the diaphragm down to the level of the iliac crest, and we scan this area every 1 centimeter, and we have some thin slices covering the pancreatic area. And you know that the pancreas is an retroperitoneal structure. It lies oblique in the abdomen. The tail is above and the head is lower down. And these are the usual measurements of the pancreas. The head measures about 3 centimeter, the neck and body about 2.5 centimeter, the tail is about 2 centimeter. Then the pancreatic density is almost similar to the unopacified bowel loops, and we usually scan the pancreatic area every 5 millimeter slice intervals. One of the important findings is to know that the pancreas does not have a firm capsule, and this will enable the inflammatory process to spread to spread in the peripancreatic fat, as we will see. Then whenever you are having cuts through the abdomen, and you will face first the pancreatic tail, then the body, and lastly you will see the pancreatic head. But in some cases, the pancreas is lying horizontally in the abdomen, so in a single slice you can see the whole pancreatic anatomy, the head, the neck, the body, and the tail. And you remember that this vessel is the splenic vein passing posterior to the body of the pancreas. This is the normal appearance of the pancreas by CT. First, you can see most of the pancreatic body and tail with the splenic vein passing posterior to the pancreatic body, and lower down you'll see the pancreatic head identified by the superior mesenteric artery and the vein. And you remember that this small hypodense dot represents the normal common bile duct. Once more, this is the normal anatomy of the pancreas. You see the pancreatic body and tail. Lower down you see the pancreatic head identified by the superior mesenteric artery and vein, and in this patient you can see a sizable gallbladder calculus. In old age, the pancreas usually shows some atrophic changes, and you can compare this to the normal appearance of the pancreas in young age, and this is the normal appearance of the pancreas in old age. The pancreas is relatively smaller in size and is also infiltrated by fat, and this will not affect the pancreatic function in most of the cases. This is the appearance of the pancreas by MRI, and this is the T1 weighted image, and this is the T2 weighted image. And here you can see, and the T1, this is the body and tail of the pancreas, and the T2, this is the body and tail of the pancreas. And in the T2, this is the site of the pancreatic head, identified by the superior mesenteric artery and vein, and you see the common bile duct showing high signal fluid in this T2 weighted image. Then you know that the pancreatic pathology is extremely limited, and we have two only main pancreatic lesions we can face in the clinical practice, and these are pancreatitis and pancreatic neoplasms. Then starting by pancreatitis, we have two types, the acute pancreatitis and the chronic one. And in the acute sector, we have two types. One, which is very common, is the edematous type, and the second is rare or relatively uncommon, which is the hemorrhagic type. The causes of pancreatitis include trauma, surgery, infection, gallstones, and penetrating peptic ulceration. And in order to diagnose acute pancreatitis, you have three main findings. Number one, diffuse pancreatic swelling of the pancreas. Number two, dirty appearance of the peripancreatic fat, or smudging or stranding of the peripancreatic fat, and the presence of peripancreatic fluid, either free or encysted. And this is the case of acute pancreatitis. You can see that the pancreas is swollen, and there is a lot of fluids around the pancreas, obliterating the peripancreatic fat planes. This is once again a case of acute pancreatitis. You see the pancreas is swollen, and you see dirty appearance of the peripancreatic fat planes, and you have got a lot of fluids in this area, anterior to the kidney and posterior to the pancreas. Then, as I have said, the peripancreatic fluid may be seen in the free state, as you can see here, or being encysted and forming what's known as the pseudo pancreatic cyst. This is acute pancreatitis. The pancreas is relatively swollen, and there is free fluid almost encircling the pancreatic area and obliterating the peripancreatic fat planes. These are some of the ancillary findings in assessment of a case of acute pancreatitis, including blurring of the pancreatic borders. Number two, thickening of the perirenal fascia. You know, the Girotta fascia is present here, separating the perinephric fat from the paranephric fat. And you see that this Girotta fascia is bordering the fluid, which is the sequelae of acute pancreatitis, giving this sign which is known as the renal halo sign, because the kidney is supplied by a halo of hypodense fat being bordered by the Girotta fascia. Then being adjacent to the stomach, there may be some focal gastric wall thickening, and also there may be some pleural effusion, especially on the left side. This is acute pancreatitis by MRI, and this is T1, and this is T2, and this is T1 post contrast. You can see that the pancreas is swollen, and the peripancreatic fat is dirty or stranded or smudged due to the spread of inflammatory process. Then the complications of acute pancreatitis include the formation of pseudopancreatic cyst, or a formation of an abscess, or vascular thrombosis, or hemorrhagic pancreatitis. And if you look here, and this is the pseudopancreatic cyst, which is a collection of fluid around the pancreatic area in the course of acute pancreatitis. The incidence is about 2 to 10%, and this pseudopancreatic cyst is usually well formed 4 weeks after the onset of acute symptoms, and this may remain within the pancreatic capsule or may extend into the lesser sac or retroperitoneum. You see a big pseudopancreatic cyst affecting the or intimately related to the region of the body of the pancreas. And this is also another example of a big pseudopancreatic cyst in the region of the pancreatic area in the course of acute pancreatitis. This is called the pseudocyst because it has no epithelial lining, and the wall is formed by granulation tissue, which will mature into a fibrous capsule later on. Most or no, a large number of pseudopancreatic cysts may resolve spontaneously, especially if they are small, within a period of 6 weeks. And after 6 weeks, a fibrous capsule will develop, and the pseudopancreatic cyst needs to be drained either percutaneously or surgically. Then you see a case of a pseudopancreatic cyst, which is a large hypodense fluid collection in the region of the pancreas in a case of acute pancreatitis. And this is also a pseudopancreatic cyst in the region of the pancreatic head. This cyst may be mistaken for cystic tumors like mucinous cystadenoma of the pancreas, as I will mention in the sector of pancreatic tumors, but you can spot the diagnosis, of course, by the clinical data and the laboratory findings where the serum amylase level is markedly elevated. And also you can aspirate the pseudopancreatic cyst and assess the serum amylase in the fluid of the cyst as well. Then pancreatic abscesses may develop or may be seen in 4% of cases of acute pancreatitis. The pancreatic abscess is diagnosed by the presence of a fluid collection with a thick enhancing margin in the region of the pancreas, and very importantly is the detection of gas inside the collection itself. And according to the literature, gas is not commonly seen in pancreatic abscesses, but it is considered the only landmark to differentiate between pseudopancreatic cyst and abscesses. Then if you see a collection in the region of the pancreas in a case of acute pancreatitis, and this collection may represent a pseudopancreatic cyst or an abscess. But if you detect air inside this collection, and you may be sure that this cyst is in fact an abscess in the region of the pancreas. And the role of CT in cases of pancreatic abscesses is to confirm the diagnosis and to demonstrate the extent of the lesion and the full size of the lesion, and sometimes guides the interventional procedures as percutaneous catheter drainage of these collections. Then pancreatic abscess versus pseudocyst. Gas in the abscess may come from gas-forming organism or fistulous communication with the stomach or bowel. And as I have mentioned, that the presence of gas is the only way to differentiate between pseudopancreatic cyst and an abscess, and considering that gas is not usually seen commonly in the peripancreatic collections. Then hemorrhagic pancreatitis is considered a medical emergency, and this will happen if the inflammatory process has affected one of the vessels and lead to the development of hemorrhage in the region of the inflamed pancreas. Then significant hemorrhage occurs in about 2 to 5% of cases and is usually an indication for urgent surgery to control the bleeding. Then necrotizing pancreatitis, meaning that the blood supply of the pancreas has been occluded due to vascular thrombosis in the course of inflammatory process. Then you can compare the normal appearance of the pancreas and the necrotic pancreatitis. You can see that the pancreas is swollen and there is no enhancement of the parenchyma of the pancreas, denoting compromise of the blood supply. and this is also a case of necrotizing pancreatitis affecting most of the pancreatic body and the neck. And you can see that a small part of the pancreatic tail is still surviving, showing contrast enhancement. And around the pancreas, a significant amount of fluids are seen. Then necrotizing pancreatitis or emphysematous pancreatitis, meaning that there is air loculi in the inflamed necrotic pancreas, as you can see in this condition of necrotizing pancreatitis. Then the diagnostic hallmark of chronic pancreatitis is the detection of calcium within the affected pancreas. And calcification can be seen even by the plain film, as you can see in this case with dots of calcification along the course of the pancreas, diagnostic of chronic pancreatitis. Ancillary findings of chronic pancreatitis may include pancreatic atrophy and the dilatation of the main pancreatic duct. But you should remember that the whole diagnostic landmark of chronic pancreatitis is the presence of pancreatic calcification, as you can see in this case. And this is also a case of chronic pancreatitis showing dense calcium along the course of the pancreas. And you may appreciate that the main pancreatic duct is slightly dilated, and you remember that the normal duct diameter of the pancreas is about 3 millimeter with gradual tapering to the tail, and the normal duct is not usually seen by regular CT scans of the abdomen. It needs a high resolution scans with small slices in order to identify the normal pancreatic duct. Then we have finished with pancreatitis, the acute and the chronic type, and we mentioned the complications in cases of the acute pancreatitis. Then we came to the issue of pancreatic tumors. And we have three types of pancreatic tumors: the solid ones, and the cystic tumors, as well as the islet cell functioning tumors. Then considering the solid tumors, we have two main diagnostic landmarks for diagnosing a pancreatic tumor. Number one is the focal change in size and shape. Number two is abnormal density. And if you look here in this example, and you see that there is a mass arising from the tail of the pancreas, then there is abnormal contour deformity and abnormal enhancement compared to the normal enhancement of the pancreas. Other findings may support the diagnosis, like obliteration of the peripancreatic fat, which is more commonly seen in inflammatory conditions, and also dilatation of the common bile duct, especially if the tumor is in the head, obstructing the region of the ampulla of water. And also it may result in dilatation of the main pancreatic duct, what is known as the double duct sign, the common bile duct and the pancreatic duct. Then regional lymphadenopathy, metastatic lymph nodes, and vascular encasement are also some of the supportive signs. Then look here for a case of carcinoma of the pancreatic head. Then you see a mass in the region of the pancreas. There is a contour deformity and a lesion in the head compared to the body and the tail, and you got abnormal density and heterogeneous enhancement. You have the double duct sign. The main pancreatic duct is dilated, and the intrahepatic biliary radicals are dilated, denoting obstruction of the common bile duct. And the double duct sign can be seen clearly in this condition. Also here you see a small mass in the pancreatic head. The pancreatic head is not enlarged in this case, but it shows heterogeneous enhancement, and this is one of the important issues for the diagnosis of pancreatic tumors. You see the superior mesenteric artery and the vein, and if you look in the liver, you can see dilated biliary radicals due to obstruction of the common bile duct. And you remember this case I have shown in the lecture of biliary imaging. You got the dilatation of the intrahepatic biliary radicals, dilatation of the common bile duct, and you got a mass in the region of the pancreatic head, representing a pancreatic tumor. Then if you look carefully, and this is the portal vein, and the portal vein is partially enhancing, and you see a filling defect inside representing a thrombus. Then going to the region of the superior mesenteric artery and the vein, and you can see that the superior mesenteric vein is not homogeneously enhanced. There is a filling defect inside representing thrombosis. Then in this case you got thrombosis of the superior mesenteric vein as well as the portal vein. And in this case you can compare the normal pancreatic head and the pancreatic head containing carcinoma. This head is relatively enlarged and it shows heterogeneous contrast enhancement with areas of breakdown inside. Then focal enlargement of a part of the pancreas is usually suggestive of a pancreatic cancer. Then abnormal attenuation and enhancement, and this sign cannot be reliably judged unless you have injected the patient with intravenous contrast media. And vascular invasion, either the superior mesenteric artery or the celiac artery, indicates that this tumor is inoperable. And you see here a case of pancreatic head carcinoma. The pancreatic head is enlarged. It shows heterogeneous enhancement with areas of breakdown. And if you look carefully inside the liver, you can see some dilatation of the intrahepatic biliradicals. And in this case, you see that the pancreatic head is grossly enlarged, and this is the biliary stent, which is usually applied in cases of pancreatic head cancer associated with biliary obstruction perioperative. And you see that the tumor is encasing the superior mesenteric artery. The head is enlarged, it shows heterogeneous enhancement, and the superior mesenteric artery is going within the tumor tissue, indicating that there is vascular encasement, which indicates inoperability of the lesion. Then you may support your judgment by having a CT angiogram of the superior mesenteric artery. And here you can see this is the origin of the artery, and this segment is narrowed corresponding to the site of the tumor, which is seen encasing the superior mesenteric artery, as you can see in the axial sections. This is the site of the tumor, and this is the normal size of the pancreas. The pancreas here is atrophic because the patient is above 70. Then diagnosis of the superior mesenteric vein thrombosis is easy with regular CT scans of the abdomen after injection of intravenous contrast medium. And this can occur separately of any pancreatic tumors, as you see in this case. This is the normal appearance of the superior mesenteric artery and the vein, and this is the pancreatic head. This is the common bile duct. But in this case, you see a normal pancreatic head, normal superior mesenteric artery, and a thrombosed superior mesenteric vein. Also, the presence of metastatic deposits, the presence of lymphadenopathy, the presence of ascites can support the diagnosis of pancreatic cancer. You see here a mass in the body of the pancreas. The body of the pancreas is enlarged. It shows heterogeneous contrast enhancement compared to the head, which shows homogeneous enhancement, and this is the common bile duct. And if you look carefully in the liver, and you can see multiple hypodense focal lesions representing metastatic deposits, and also you can easily appreciate the presence of multiple gallbladder calculi. This is a case of pancreatic tail carcinoma. The pancreatic tail is enlarged. It shows heterogeneous enhancement compared to the pancreatic head, which is normal, showing homogeneous enhancement. This is the superior mesenteric artery and the vein, and this is the common bile duct. And also you can see that there are multiple lymph nodes around the celiac, the superior mesenteric axis. This is the lymph node, and these are two other lymph nodes. This is the aorta, and this is the IVC. Then in the liver, you can see also multiple focal lesions representing metastatic deposits. And this is the case of pancreatic tail tumor with significant enlargement of the pancreatic tail showing heterogeneous contrast enhancement. And in the liver, you can appreciate the presence of multiple focal hepatic lesions representing metastatic deposits. And it is usually stated in the literature that this type of pre-processed meat is one of the predisposing factors for pancreatic cancer. Also here you see a mass in the region of the pancreatic head and body. The mass showed a relative less enhancement compared to the enhancement of the pancreatic tail. If you look carefully, you may appreciate that the main pancreatic duct can be seen, it's not dilated, and also the liver does not contain dilated biliary radicals. But here, if you look carefully, you can see a focal lesion in the spleen, and you can see also a mass in the kidney. And this is the case of lymphoma affecting the spleen, affecting the kidney, as well as the pancreas. And in the literature of splenic imaging, I will mention that the most common solid splenic focal lesion commonly seen in the clinical practice is usually due to lymphoma. Then if you see a solid lesion or multiple lesions in the spleen, and you may predict that this is the lymphoma, and based on this diagnosis you can diagnose this focal lesion as lymphoma as well, and the mass in the pancreas as lymphoma, and also the mass in the kidney as lymphoma. Then pancreas can be the site for metastatic deposits, especially if the patient is known to have a primary malignancy, like in this patient with renal cell carcinoma that has been removed, and you got multiple masses in the head of the pancreas. There is a mass, and in the tail of the pancreas there is another mass, which are heterogeneously enhancing, representing metastatic deposits. And this is also a case of renal cell carcinoma with pancreatic metastasis in the region of the head. If you look carefully, this is the atrophic body and the tail of the pancreas, and inside you can see that the main pancreatic duct is dilated. Then this is considered a contour abnormality and also abnormal enhancement compared to the rest of the pancreas. Putting into consideration the patient and the primary malignancy, then the diagnosis is suspected to be due to metastatic deposits. Then we came to the cystic tumors, and we have two types. The cystic tumors represent about 15% of the pancreatic tumors. We have the mucinous cystic tumors and the serous cystic tumors. The mucinous cystadenoma and cystadenocarcinoma are by definition large cystic lesions affecting the pancreas, and these cystic lesions may contain internal septation and may also show calcification. But if you detect the mural nodules, then you are dealing with the malignant version of this tumor, the mucinous cystadenocarcinoma, for example. This is a good example of mucinous cystadenoma, a big cystic lesion in the region of the pancreatic tail, and you can see fine internal septations inside the lesion. If you detected the mural nodules, then you suspected that this is the carcinoma type, not the benign form. And this is another example of mucinous cystadenoma of the pancreatic tail, a big cystic lesion showing low signal in the T1, high signal in the T2, some internal septations, and you got some calcium inside the tube. Then the serous cystadenoma is usually known as the microcystic adenoma, and it usually seen as multiple small cystic lesions may affect a part of the pancreas or may affect the whole course of the pancreatic tissue. And here you can see multiple small cystic lesions scattered along the pancreatic body and the tail. And these cysts are usually smaller than 2 centimeters in diameter, and they may also show calcium similar to the mucinous type. Then this is a pancreatic microcystic adenoma, and you see a cystic lesion with internal septations and calcification in the region of the pancreatic tail. Another example of microcystic adenoma of the pancreas with multiple small cystic fluid containing lesions in the region of the pancreatic tail. And this is another example of serous cystadenoma or macrocystic adenoma of the pancreas, and you can see multiple fluid containing cystic lesions related to the region of the tail and the body of the pancreas. Then you remember in the lecture of the hepatic imaging that cystic lesions may occur in the liver in the course of polycystic disease, and also these cysts may affect the kidneys and sometimes may affect the spleen. But remember that congenital pancreatic cysts are rare, and the cysts usually seen in the pancreas, especially if they are numerous like in this case, are usually associated with this very known disease, von Hippel-Lindau disease. And then if you see multiple small cysts affecting the whole pancreatic tissue and the pancreas is grossly enlarged, then you may suspect the possibility of von Hippel-Lindau syndrome or disease. Then we came finally to the islet cell tumors, and we have too many lesions, but the most important ones are the insulinoma, which represents about 70% of the tumors, and the gastrinoma, which represents about 20% of these tumors. We have also the glucagon producing tumors, the vasoactive intestinal peptide producing, and this is VIP non-beta cell tumor, and somatostatin producing tumors. Then one of the well-known findings about insulinoma that it is usually presents by a small tumor which is hardly detected by imaging, either CT, ultrasound, or MRI. And this tumor accounts for about 1 to 5% of all pancreatic neoplasms, and it has a good prognosis compared to the pancreatic carcinoma. The lesion is vascular, and it shows contrast enhancement, and is well demonstrated in the venous phase. And this is a case of insulinoma demonstrated by MRI. This is T1 before contrast, and you see very small very small low signal lesion in the approximately the region of the neck of the pancreas, and the lesion turned hyper intense in the T2 weighted image, and after contrast it shows some contrast enhancement. Then here you can see that the insulinoma has a low signal lesion in this T1 and the relative increased signal in this T2, and you cannot appreciate the tumor after injection of contrast medium. Then islet cell tumors can be multiple or can be single, and you see this contrast enhanced CT scan showing this enhancing focus in the region of the pancreatic neck, representing an insulinoma. And you know that insulinomas are usually diagnosed by the clinical presentation and the laboratory findings. And one of the most important tools for detecting insulinoma is the intraoperative ultrasound. Based on the laboratory and the clinical finding, the clinician is sure that the patient had an insulinoma. Then they open the abdomen and put the ultrasound probe directly on the pancreas, searching for the site of the tumor to be surgically removed. And here is a case of the insulinoma of the pancreatic neck, showing a relative contrast enhancement in this contrast enhanced CT scan. And many times we perform CT scans or even MRI before and after contrast injection, and we cannot usually detect this very small tumors. And you see a mass in the region of the pancreatic tail, and commonly you should diagnose that this is a pancreatic adenocarcinoma, but it happens after biopsy or surgical excision, that you can see that this tumor belongs to the islet cell tumors, and you know that islet cell tumors may be functioning or non-functioning. And it is stated in the literature that if you see a mass in the region of the pancreas and you detect calcium inside this mass, then you should think of islet cell tumor, because the carcinoma or the adenocarcinoma of the pancreas almost never shows calcification. Then this is not 100% diagnostic sure sign, but it may help you to predict the nature of this tumor. And you know that I have mentioned this syndrome, Zollinger-Ellison syndrome, whenever I discussed the issue of gastric imaging with in the talk about the peptic ulceration. You remember that Zollinger-Ellison syndrome is formed of a triad, which is composed of gastric acid hypersecretion, severe peptic ulcerations in almost all cases, and the presence of a non-beta cell islet tumor of the pancreas, which is known as gastrinoma. And this syndrome is presenting clinically by abdominal pain and diarrhea, and the severe type of peptic ulcerations, which are usually multiple and occurring at abnormal locations. This is a gastrinoma, a mass, solid mass in the region of the pancreatic neck and body. And you are not able from the imaging per se to suspect that this is gastrinoma unless you have the clinical data and you know that this patient had the triad of Zollinger-Ellison syndrome. Then you may predict that this is gastrinoma. And this is also a non-functioning islet cell tumor of the pancreas. It exactly simulates pancreatic adenocarcinoma, and you cannot differentiate between both unless you may have the clinical data. But in cases of non-functioning tumors, the only way is to have a biopsy from this lesion to confirm the diagnosis. Finally, we came to a tumor which is relatively rare, and this occurs in almost exclusively in young women. And the tumor is a sizable lesion composed of solid and cystic components, and it may contain hemorrhage and calcification. Then if you see a mass in the region of the pancreas, and this mass is partially cystic and partially solid in a young female, you may suggest this type of the tumor, which is known as solid and papillary epithelial neoplasm, or the France tumor. As I have mentioned, this is a rare type of low-grade malignancy, and it is potentially curable if surgically removed. There is a possibility of non-recurrence, but in the literature they stated that there may be in some cases local or distal recurrence, and also some hepatic and peritoneal deposits. And this is the appearance of the tumor. As I have mentioned, you got a big lesion in the pancreas, and this lesion is partially cystic, partially solid, and is usually seen in a young female patient. The presenting signs and symptoms include palpable abdominal mass, sometimes pain and vomiting, but in many cases the patient is usually asymptomatic. Then the main differential diagnosis of this tumor may include the microcystic adenoma. Of course, you remember that this microcystic adenoma presents by multiple small cysts, and you got some septation and some calcification inside, and it's usually seen in older age group. The mucinous cyst adenoma are typically large, they are multilocular, they contain septations, and they may show calcification. But solid component in the tumor will indicate that this is a malignant type of the tumor. Then non-functioning islet cell tumors, like the examples you have seen, are typically hypervascular. They are usually large with necrotic areas at the time of the diagnosis, and you see a significant enhancement. Hemorrhagic pseudopancreatic cysts, they do not contain solid component, of course. They contain fluid and they contain hemorrhage, and they are seen in the course of acute pancreatitis. And the clue for the correct diagnosis is the clinical data and the laboratory findings. هذا وبالله التوفيق والحمد لله رب العالمين.